Hey Fix listeners, I want to take a minute to give you all an update on our DPO, Smile Now Dental Group. In case you haven't heard, we've been opening up locations all across the country for doctors just like yourselves. We started several offices this year to show proof of concept, and it's been off to the races ever since. So if you're looking for an equitable partnership opportunity where you can have a profitable business that supports you doing full arch, I'd love to hear from you. We're looking to add several locations in the next year and want to offer the training and support necessary to make one of those yours. If you'd like to learn more, you can go ahead and hit me up on Instagram at Dr. Tyler J. Tolbert, or shoot me an email at tyler@smilenowdentalgroup.com and say hey. Now, without further ado, let's get back to the show. My name is Dr. Tyler Tolbert.
And I'm Dr. Soren Poppy,
And you're listening to the Fix Podcast.
your source for all things implant dentistry. Yeah, I think the other consideration as well, and I agree with all that, and I think it is interesting because everybody that's coming up in the implant dentistry, they all have different backgrounds, right? So like you said, Bernardo, maybe he's just seen a lot of complications with zygos, and that's enough for anybody to say, maybe this isn't the best route for me.
For sure. Yep.
And I think like one thing that a customized implant can't do is what you described earlier. So you were doing conservative approaches, you tried the palatal approach, you did the transsinus, you weren't getting anything. So then you pivoted to a zygo intraoperatively.
I was going to say
You can't
that
do
too.
that with the customized implant.
Yeah.
That's out of the bag. So you have to have something for what happens on the day.
And I'll have the patients that I treat just sign a zygotary consent form, because you can't
Might happen.
mid treatment say, hey, do you mind if I do this, Mrs. Jones? So just having that, and does it happen all the time? No, but when it does, it's great. You're going to get the outcome that you're paying me for, not the implant.
So this is a bit of a tangent. And Soren, I don't mean to leave the question.
You just mentioned it. It was exactly what you said.
Oh, okay.
Yeah, I was going to say pivoting. It's hard to do that
Yeah.
when you have to have a CT spliced weeks prior and then a custom implant come.
Yeah, you just got to have it ready just in case. Just pay $5,000 for the backup. But no, my question. So you brought up something that I've been asked about before is a zygo Terry specific consent form. So I'm curious about what sort of things need to go into that, because I've had some people ask me about this. Is do I need to talk to my patients about pterygoids if I'm going to be doing that? What do they need to know? Do they need to know? What kind of special considerations are there?
When I took Vishy's course, he basically gave everybody a consent form that he used. So I'm more than happy to send it your way. But I think a lot of it is just, hey, what do the malpractice carriers want you to talk to your patients about? Nerve damage, eye stuff with zygos, recession, sinusitis. I think the pterygoid, the biggest risk is some sort of bleed.
Yeah.
But yeah, I think if you select the cases correctly and you don't try to be too much of a cowboy, I would say that posterior lower zygos are, I think, easier sometimes than pterygoids. And I think people are like, no, I'm going to learn pterygoids first because there's not an eye next to it. And that's like the kind of, they don't maybe talk it out, but I think that's what they're thinking, or they have that thought process. And then once you get at both of them, you're like, oh, I could just do lower posterior zygos all day. And versus, God, you miss on the Terry and got to find a new spot. And maybe it's more difficult to get your photogrammetry unit back there. There's all sorts of like different like little nuances to it. Jaw form, arch form, patients gagging, stuff like that. But yeah.
I think that, so what I liked is one of our first courses learning zygos was at the Texas Implant Institute with Clark Damon, Rick Klein, the late and great Juan Gonzalez, and they taught both at the same time. So we learned Terry's and zygos. And I think in general, when you're getting to the point of wanting to get into remote anchorage, the sort of cases that you'll want to utilize Terry's for are still standard all-in-4 adjacent, right? Like you can do Terry's on the standard all-in-4 case to add more support and give it more utility, give you backups and stuff like that. But when you start getting into zygos, those are inherently going to be more extreme, more atrophic cases. So I think learning that lower posterior zygo, that unilateral zygo, should it come into play, is good to have. But you're approaching cases where it's, okay, standard plus Terry. And I'm going to get comfortable with cases that can be secured with the front four, but I'm going to try some Terry's and try and get my feet wet with that. And then you're just keeping that zygo in the back of your mind. Okay, I did that 100 times. I did it on cadavers, I did it on models. If the time should come, then I'll be ready for that and have it as a rescue implant for a while. And then once you're really comfortable with Terry's, then you start taking on even more atrophic cases. And now that zygo is more likely to come into play. I think that's maybe a better middle ground to approach it But I can totally agree, though, that I can see where the difficulty of getting comfortable with teres is almost a little bit greater than that lower posterior inferior zygote, because you can see that one. The teres is like you can almost close your eyes and be just as good.
Yeah, I don't disagree with you. I think one of the things that really helped me also was I would print models and practice on them ahead of time, and just getting those reps and the mental, this is what it looks like, and going through that visualization process, as well as having a model chair side where I'm intraoperatively, I'm double checking and say, hey, is this the landmark that I said this is where I was going to start? Is this really where I am? And then it's almost like a little bit of a crutch, but it helps for sure.
Yeah. I think that's something I've really underutilized printing for as a biomodel, because a CBCT, you can think you have it all mapped out in your head, but for some reason, when you get in there intraoperatively, just in 3D space, things are just not where they're supposed to be. like it's easy to get lost in it. Like, all right, there's supposed to be something right here, but the spatial relationship between these two landmarks is not what I thought it'd be. You can get a little lost, but a biomodel, that's not going to be an issue. So I think that's a good idea to have that on.
I'm not an expert in 3D printing, but I went out and helped Alex Smith do a zygote case in Oregon, I don't know, 6 months ago. He is an awesome lab guy, beautiful new office. Wish him and Tom the absolute best. They're great guys. For any case I go mentor, I'll print models and then take them with me. And this lab guy was like, oh yeah, I used Blue Sky's new auto segmentation, and it took me 10 minutes and printed this in $15 resin. I had it professionally done for like $100 because I'm not going to like segment out. So I was like, you kids have it all figured out.
I was just going to say a quick tip that I'm sure a lot of people appreciate hearing, and I'll try not to hide it anymore, is the easiest way to do it. And maybe Blue Sky Bio now has an even easier way. I don't know. But if you go on, it's relu.eu, RELU.eu. It's a like AI segmentation software. So all you have to do is whatever your CT program is, you just export your DICOM, upload it onto Relu. It splices it out for you. Super easy. And then you can just download the STL and you can print it on your $300 frozen printer. Just with the traditional plate, you can use Frozen's water washable resin. It's $30 for a liter. So cheap.
On Amazon.
And you can print it. It's super easy to print, and you have a full skull for like literally, I think the most expensive thing is to splice each CTU splice is $3 or $4 or something like that. But like for what you paid for probably 4 of your professional models, you could buy literally the printer, the resin, and be able to do them forever. So if you're listening and you're like,
a life hack for you,
man, like I'd love to be able to do biomodels, but I don't want to pay $200 on this case. Do it like that. It's super straightforward, and that's like the walkthrough. I figured it out by myself, and it's not hard to do. The Relu, it's RELU.EU is like super basic software. All you do is upload your DICOM, you export your STL, and then you can just print it right on the frozen. You can't really print it well on a Sprint Ray or on any printer that doesn't have a large build plate, because obviously you want a large enough build plate to print like the maxilla up to the zygos, like in the inferior aspect of the orbit. But if you have a frozen, the build plate it comes with is pretty large, and it's a really easy way to make biomodels for any kind of case. You can also get your pterygoids in there, your zygos. Even if you're just getting started with traditional all-on-4, it's an awesome way just to be able to visualize the anatomy of the maxilla.
Does that water washable, does that drill okay if you ever wanted to actually practice on them?
You can drill into it.
Too hard?
No, you can definitely drill into it, but it's not.
Don't ever use the drill.
No, I wasn't going to say that. I was just going to say it's not like the same feeling you get with bone. So there's a couple 3D printers that have like the filament resin
FDMs
that is like specific for bone. So it's like very similar to bone. But if you want to go off the deep end and get really into biomodels, that's what I would recommend doing. But the filament resin that's like similar to bone is crazy expensive. If you just want it for visualization purposes, definitely just print in frozen water washable on a frozen, like, what is it? The Sonic 8K. And the whole setup is going to be less than $400, and you can print models for the rest of your life. And that's like a whole nother, like, if you want to get into that stuff, Rick Ferguson has a really good dental group that talks about frozen. But I actually for a year, printed all of my stage 2 models in wrote in Titan on my frozen $300 printer. And I genuinely think that the prosthetics I got were more accurate than those that I had printed on any of my other printers. It's pretty crazy what that printer can do if you have the settings correct. That being said, a lot of times it takes 2 or 3 prints because the printer is a little bit finicky, and it does take 2 hours to print something. And if you're printing a model, it's like it takes overnight. You just print it overnight. It's not like a 20-minute print, but it does do really nice work. And that's like a whole nother avenue that don't get me started.
But between Rick Ferguson and the 3D printing dental group, you'll get better customer support on that printer than you will any legacy dental company. I'm telling you right now. You get immediate, like, in your computer, let me fix this for you type support. It's amazing.
It is.
We have an incredible community.
The next thing I wanted to talk about, Chris, was what are some of the more common mistakes that you've seen docs run into being, and I know we've talked about like treatment planning, right? That's a big one, but like just with traditional all-on-4, what things do you think, what do you wish you would have known when you first started getting into it? And then what do you wish you would have known when you first started getting into remote anchorage cases?
Let's see here.
Hey guys, I just want to take a beat to talk about one of our sponsors, SIN 360, specifically their full arch digital workflow. Here at the Fix Podcast, we've been using SIN for about 2 years, and one of our favorite integrations from this workflow is the Micron Mapper. Photogrammetry is an absolutely pivotal technology that has changed the way full arch is being done. It's allowing us to capture implant scans in under 5 seconds with micron level accuracy that's beating any type of scannable verification jig or analog verification jig, what have you, and it's able to do it in under 5 seconds. And guys, SIN 360 is absolutely giving this thing away right now for $699 a month for 39 months with 0% financing. Think about that, $699 per month. That's about the cost of an analog conversion or fabricating an analog verification jig, or maybe even just a scannable verification jig. So I highly, highly, highly recommend you try this out. It's one of the most pivotal investments that you can make in a full arch digitally capable practice. To learn more, visit sin360.us/thefixpodcast and get yourself a Micron Mapper today.
Things for basic all-on-4 would be having the ability to have an anesthesia provider in-house. Sorry, one sec. Yeah. All right. Basic all-on-4s, things that I would do different or things that I wish I would have known about. I did some IB sedation training, but I never really utilized it. I will say trying to complete these cases as double arch cases with local anesthetic over a long period of time, it causes surgical fatigue, and you are boxing yourself in to a corner that as you're starting to do this, you're adding pressures that you don't need to add. So I would be saying phase your cases. If you're doing them with local, just do the upper, get it done, set the bite, come back to the lower, live to fight another day.
Yep.
You can take more time to do each step in a very excellent way so that step 2 builds off of step 1. And as soon as you're 5 or 6 steps in and you're battling something and you just have this surgical decay, you're starting to compromise. And a majority of the time, what happens is the young docs or the new ones into it, they compromise on their plasty because their flap isn't big enough.
The cardinal sin.
They're feeling something, and as soon as you don't plasty correctly, you're causing a problem for you and the patient. And that's probably like the biggest. That was a very big realization. Once you do that one time and you see the outcome of, okay, this is not exactly how I wanted it, but you just don't do it again. So phasing the cases, if you don't have the ability to provide better anesthesia, what else from some of the basic stuff? Just the treatment planning and reading the CBCTs, the ability to just, and this just comes with reps, but you just see the problems before they happen. Teeth that are spaced really closely together. And so all the roots are right next to each other. And there's just like cribiform plate after cribiform plate. And you just, there's no intramedullary bone between any of them. And you take everything out and you're like, why is this case different than like these other cases? And it's like some of the nuances of it. So just those reps will help. The remote anchorage stuff, Yeah, what would be some like really good takeaways?
Before you go into
I'm
that,
curious too about.
Yeah, go ahead.
oh, I was just gonna, before you go into that, I was just gonna say that I've seen so many doctors fatigue out uh, because they weren't
Okay.
able to provide adequate sedation, and they've had patients that they couldn't get numb, and case after case was just like a nightmare. And in my, that's how I started too, oral conscious sedation for my cases. And I remember like one or two cases in particular that just went, not that the outcome went bad and, like, all the implant positioning, everything was good, but the patient just had a miserable time, and so did I during the case,
Yeah.
because they were just one of those patients that it took a little bit more to get them numb, and then you're battling with your limits of epinephrine, your limits of anesthetic, and
100%.
I think it's much now it's funny because I stopped doing oral sedation after a couple of those. I was like, I'm only doing patients under IV sedation," and I really think that's if you're able to offer that service is 100% the way to go. And now that me and my team are so much more efficient with these cases, I do oral conscious cases pretty frequently actually, and they are a breeze. And the reason that they're a breeze is because I'm efficient, my team's efficient, we can get in there and get out of there in a timely manner. And it's way
Yeah.
better to be a provider that's if you're just getting started in these, if you have a clinic that is you're just starting up or like you are or like getting into more fixed cases, do IV sedation first and maybe price your arches a little bit more. And then when you want to get more competitive and you want to get more reps, you can drop that price a little bit and take out the sedation aspect and offer oral conscious when you know that your team is prepared and you're prepared to be able to do these cases efficiently.
Yeah. I think that's a good call. I think I remember, I think the phasing of the cases too,
Mhm.
I think everybody feels like they got to do all the doubles at the same time. I remember Mike Frymouth, he would do these staged cases of these FP1 cases where extract some of the teeth, place some implants, graft, he'd prep the other's teeth, and then they leave in basically this like molar and canine, like provisional. And they'd come back 4 months later, slick the other teeth, pick up the implants, maybe place two more and attach a new provisional, all those other ones. So it's a longer period, but the patient always had a very nice temporary bridge that would really look and function like teeth. And you had a provider that was very confident that would deliver the treatment just like they said that they were going to. And the patients were okay with it. The big thing is when we overpromise and underdeliver, and then patients aren't okay with that. So if, like you're saying, Soren, if you tell the patient, hey, this is the best option for you, and this is the way that I would treat you if you were in my family, they're going to believe it, regardless of whatever it is. I've got a buddy in Kansas City. He doesn't immediately load anything, and he does arches all the time. And he says, hey, the best course of treatment for you is for these implants not to have anything on it. He gives it. Do I agree with that? No, but does that work for him in his practice? Just like you're saying, if you need more reps and you need to do a certain thing and you need to tell your patients, this is like the best thing for you to do right now, just 100% do that to get a good outcome for you in your office.
Yeah. Yeah, absolutely. Tyler, you were going to say something?
Yeah. So I love all the advice for people who are just getting started, looking to do full arch the right way. And if you listen to this podcast, that's what it's all about. What would you say to some of the more, let's say, moderately advanced practitioners? So they're past 500 arches. They've done all the traditional M4 one can do. They have advanced techniques. They're comfortable with teres. They're starting to wade into the revision territory, zygos, things like that. What are some key things that you would give to someone who already knows a lot of that stuff? What are like some of the finer points of those really advanced cases that you've picked up along the way?
I don't know if there's like a necessarily like a really definitive thing. I'm trying to think through maybe some of my earlier cases or things that I would do differently. Maybe I think the biggest thing would just be choosing easy cases to start. So going back to that thing, where it's just because you did the course, I would not come back and do like a quad just because that was the first case that walked back in your office, because you're setting yourself up to have problems. And now it's that whole thing of you get burned by your first 2 or 3 cases and you potentially don't want to do another case. Yeah. So I loved what you said earlier, Tyler, where I have a great case already, regardless if I do any remote anchorage. Yeah. And I'm going to add pterygoids. And if I don't get the pterygoids or it's not exactly how I want them, no harm, no foul, patient's going to get the exact same outcome. I think that's it. I think when you get beyond that and you're like, hey, I can transition at any moment and add these implants as I need to. One of the things is you get a little cavalier, and I will say sometimes I will just walk into the operatory with a little bit of the attitude of whatever's here, I'll do. And it's not necessarily like the right attitude to have all the time. Because every once in a while you're just like, hey, I wish I would have reviewed this a little bit more. Honestly, the biggest thing is relying on making the assumption that the team has all of the correct diagnostics, where not having my own office where it's like, hey, here's the protocol. I'll get sent CBCTs to review all the time. I don't always get like a high smile line photo. And I know we're getting slightly off topic, but it's one of those things where patients, when they're in that first phase of treatment and they're during their consult or their records appointment, a lot of offices will have them say, smile or smile as big as you can. And they might have not smiled for years. I remember treating a patient, putting in his teeth. He comes back for a post-op. I sat in my truck for 45 minutes practicing smiling in my rear view mirror because I have not smiled in years. So you have these patients where there's a guy who took a course, Matthew Calkins, awesome guy. He's up in North Dakota. Hey, I have my patients snarl. So patients might feel like they don't want to smile, or it's guarded, or they don't know how, but I feel like everybody knows how to make a mean face to try to get that Duchenne smile or that upper lip. So don't get complacent with some of that stuff. If you're not complacent and you have all of your diagnostics exactly how you should, maybe some of the more difficult things are practicing, getting really familiar with the anatomy. I'll say the more cases you do, the higher the reflections can go, the closer to the orbit you can be. I'm not saying be in there, but it's like you can see the anatomical difference between where the base of the zygoma is and where the infraorbital is. When I mentor cases, I will typically talk to patients about what I use as like this triangle or zone of safety, where if I can identify these three landmarks, then I feel like I always have something to go back to where I'm not lost. So it's base or the edge of the piriform rim, the infraorbital, and the base of the zygoma. A lot of times when guys or gals are first starting, they get in there and you've got the attachment of the masseter, and then they don't want to get too close to the eye. And so they end up with this like little landing strip, and they also haven't reflected up to see where the infraorbital is. And it's not uncommon that you have these little accessory vascular canals or something, and they could be way down here and thinking like, hey, this is the infraorbital and I'm not going any higher. Now you've got you've lowered your superior part and you haven't basically dissected any of the masseter. And now you have the higher inferior part. And now they're drilling like mid body as opposed to going and dividing it into two zones. So as you get better at it, you're going to start dialing in where you want your placements to give yourself more flexibility in the future if you need to revise anything or if something happens. Those are things that you just pick up along the way that you're like, hey, I've just seen this a lot before. And you just make those little mental file folders where it's like just through the reps. So I would say do these things prior to needing them. Just going back to your point, Tyler, where it's, if you're doing lateral sinus lifts, you don't have to reflect that much more to do a lower posterior zygo. Pretend that this might be a quad case and go find your anatomy and reflect how you should and clean everything. And then at the end of that, guess what? You don't have to do a quad. It feels great. Hey. And then do that 10 times. And now it's okay. Edge of piriform, infraorbital, base zygoma, right along the edge of the orbit. Guess what? There's a little ridge. Go gently find that ridge. Oh, here's a little fat. Okay, I'm not freaking out because guess what? I don't have to drill up here. You do that a bunch of times and you're just like, I'm seeing this over and over, so that when you do have that case, you're like, the reflection is not like the new part that you're like, I'm a little like antsy doing. It's no, I've done this a bunch of times. Now I just need to focus on, am I drawing my line correctly? Oh, this is something that I would say. At first, when I started doing this, I stood in the same position to do the left and the right side. And I thought I was good enough to be able to get exactly the type of implants I wanted in the same place and with the symmetry and the parallelism and everything. And what happened was that was not the case. And so I will drill the left side standing on the patient's right, and I will move around to the other side and I will drill the patient's right side standing on the patient's left. I'll end up actually I'll go back to the same spot and place the implants from the same side, but drawing my line and starting my drilling, I want to look exactly down that line. So for zygomatic implants, you can do that. It's interesting when people post their like post-op CBCTs and you look at their pterygoids, you can tell who's a right-handed operator and who's a left-handed operator. Because if you're standing in like a 10 o'clock position and you're coming around that corner and you're tapping and doing your drilling, it's not uncommon that what looks parallel or the same to you is that one side is just tipped in just a little bit more. You can see it. And the reason why I know this is because I've done that and on my post-ops, I'm like, hey, that's not perfectly the same. It's tilted in a little bit more. And what that does is it potentially kicks out the prosthetic part of it, where now that little extender that attaches to the terry might be a little bit closer to the cheek on that side. And now the patient's, hey, it rubs. Can you thin that out? Those are like small nuance things. Swallowing your ego or leaving it at the door and saying, hey, if I need to move over to a different side and make sure I can visualize this, don't feel bad about that at all.
Yeah. Okay. No, I think that's a great tip. It's funny. When I started taking teeth out in dental school with my mentor, he would like occasionally walk, even just with taking teeth out, he would go on the other side of the patient and be like, hey, like if you're like, for example, let's say you get like a root stuck, number 31, like a mesial root, you just can't get out. It's so much easier to come over to the patient's left if you're right-handed and put a crier in there or something and just pop it out real quick. And he would do things like that where he would come on the other side and be like, hey, it might not be the most practical thing. And maybe like some people wouldn't suggest, it doesn't look as cool to do, but if it makes it that much quicker for you and the patient and it more symmetry, like better outcomes, like definitely just go over there, get a better visual of it, make sure that it's done correctly, and then you're good to go.
Yeah, 100% for sure. I think the other thing too is choosing the right implant system that has the right drills and the right kits. And I do think that matters with some of this stuff. We were talking a little bit about nothing against Nobel, but I don't think they've got the best stuff as far as for doing zygos and teres. I think Neodent has some awesome stuff, but I don't love their helix long for pterygoids. I think you have to prep that differently. I'll say as like a new operator, if you are trying to figure out, like, it's already hard enough to figure out where this little landing zone is. And now you have to prepare the apical portion of this just right to get the tip of the implant to bite. Just, you don't need like that extra pressure. So you are looking for some certain styles and characteristics of some of the implants and the kits for some of these things.
So that's something I'm actually really curious about. So just to get down to the nuts and bolts. So what's your go-to Terry implant and technique?
Right now, I think Norris probably has the best pterygoid on the market. I've helped co-develop the new SIN zygomatic and pterygoid. The pterygoid is very similar to the Norris. We have some slightly different widths. The tip is maybe slightly more narrow. I do think the new kit that is FDA approved and out is a little bit better. We've got to work on the osteotomes, but as far as the design and the biting aspect of it, I think it's an awesome design as far as the pterygoids go. I have not used any of Southern stuff. Southern has a very narrow one where you can almost just use a lance drill and twist one of those in. I would like to get familiar with those.
Yeah.
I don't know if anybody's looking to head to South Africa in the next year or two for any sort of training, but make a little business right off and head down and check out what they got going on down there. But yeah, for pterygoids, you do need some instrumentation specifically that's long enough to stay outside of the mouth. That is really helpful as far as preventing user error, as far as just trying to figure some of this stuff out. I would say out of anything, the pterygoid instrumentation and the kits and the drivers and stuff like that is really pretty helpful. You can fudge stuff around using zygomatic drivers to put pterygoids in and different things like that for different systems, but to have some specific stuff is nice. I tend to not really osteotome much anymore.
Yeah.
I actually use my current setup for doing pterygoids is there's an implant company called JD. It's Italian. They have a very nice kit, and I will use their long zygoma lance drill that has a barrel on it. And from the tip of the lance drill to the edge of where the barrel is, it's 18 or 20 millimeters. So it acts as like a depth stop. Now they have specific pterygoid drills for their pterygoids, but I know if I sink that in, I'm 18, 20 millimeters in. So I'm giving myself, I'm not falling into something with a long lance or something. New users using osteotomes tend to mallet a little too hard, and you can break the plate off that way. So having something that's slow and rotary that gives you a little bit of feedback, I think is nice. So I have a Versa Zygo kit. And so I'll use that lance, and then I'll use one of the Zygo Versa Densa drills, which is longer, and you can drill it, you can keep the handle outside of the mouth. So you can densify the tuberosity if you need to. And then as you get closer, you flip it back into forward and then go back into the length that you want. And they typically place. And if you're doing oral conscious sedation, or if you are not sedated and you're osteotoming for pterygoids, I'll tell you that the patient is not happy. And it's a horrible practice builder. Having the ability to figure out how to do this without any osteotomes has been really nice.
Yeah, a
patient will never forget and
they're
going to tell everybody about it.
They were lightly tapping. They'll say, "You will not believe what this guy was doing. He was hammering this thing into my head." Yeah.
Yeah. He's putting in a rail spike.
Yeah, I have always, just because we learned from the Full Arts Club with Bernardo, and his approach is all drill driven. So I've actually I've done cadaver osteotomes, but I've always done drill. And I find that, at least for me, it works really well in my hands, because I do have that feeling, the proprioception of going in there. And I can literally, usually I just push it through the tuberosity, unless it's like really hard. And then I can just feel, I hit that cortical plate. And then what I like about it is that I can really like navigate through where the lateral and medial wings meet, and I can just poke through that. Whereas when I was doing cadavers and maybe it's just because I didn't have a ton of experience with it, but I just felt like I didn't get quite, I felt like it would slip more for me. Like it was easier to slip. And I also have seen some reports about, tinnitus with patients in the ear from that mallet stuff. And I've always been okay with the drilling protocol. That's where I fall as well.
Yeah. Yeah. Using a long lance as a probe to go back there and just push through and then find it. Yeah. I want to trademark like this probe, pop, and place, because I feel like it's the 3 Ps. And that's basically what you're doing.
Now everybody's going to know. So
put on a public podcast, man. Bad tactics.
But yes, that is great. And I'm going to have to look at the 2 drills that you mentioned, because that sounds really powerful. As far as,
I like the osteodensifying. That's really interesting. I've never thought about doing that with a tuberosity.
Kind of.
Yeah, you can go slow, you can go back and forth, and all you're doing is you're creating like a glide path to get these implants accepted. So, yeah. And the fact that they're longer drills, one of the biggest issues is that if you don't have long drills and you're trying to use like a drill extender, or you're trying to fudge it with something else.
Yeah.
That's why the osteotomes are nice, is because they're longer, they're outside, they show you the trajectory.
Yeah.
So you grab some long drills that are meant for zygos, and you know the specific depths. I'm not like public service here, like announcement. I'm not advocating zygo drills in pterygoid region. I do use them, but there's like depth stops and known measurements on these things. So
yes.
Yeah, don't go 50 millimeters down there.
Yeah. No, definitely. And that's what I do too. I actually use what I typically do, and I haven't used a lot of other kits for pterygoids besides the SIN kit. I actually have their new one on the way. I should have it next week, so I can test it out.
Yeah, the new one's all.
But I just use their long kit typically to place mine. And the way I do it is I use their lance. And usually I can get by with just a lance, but some patients, their arch form, it's really tough with their cheek to get the correct angle. So then what I do is I put their extender on it, and that really allows me to come outside of the mouth. I don't love doing that every time though, and I would never recommend it to someone who just started, because it's not a like locking mechanism in there. Now that being said, sometimes I have to grab my rongeur just to pull
it gets locked in there, welded in there.
But there is like a risk of that coming out if it was like too dense or anything like that. But I do like the ability of coming outside of the mouth, which would be a similar situation using zygo burrs but getting outside of the mouth, it allows you to correct your angle a lot better. And I see people when they're placing pterygoids, instead of getting into the correct position to place that pterygoid. They're worried more about the patient's cheek, and then you don't get the correct angle into the pterygoid. And then maybe you find out that your pterygoid, because a lot of times what ends up happening then is that your pterygoid goes lateral because you can't angle it medial enough. And if you put an extender on there or you use a longer lance, you'd be able to get outside of their mouth to place that pterygoid. And I bet you'd have better success with hitting those more often.
Yeah. That, and I would just say starting, if a lot of times docs will start their osteotomy in the center of the ridge and they're drilling at an angle. And so they're going to hit bone on an angle. And before they know it, their center of the ridge is way lateral and they've just been pushed that way. Or as the implant is engaging, it's like you've got a plate of bone and then the rest is styrofoam. And since it's at an angle, if it goes in, now all of a sudden it gets torqued and it's getting torqued out the other way as it's getting engaged. So you'll get burned a couple times, and then before you know original, you know what? I got to start way medial here because I know my end point is going to be a little bit. It's no different than like when you first learn that drilling on a narrow ridge or on a corner or on some curved bone surface. It's like, hey, start drilling at 90 degrees, and then as you go in, you're going to tip, and then as opposed to this whole sliding, and before you're off on a and maybe that's just a nuanced surgical thing, but starting maybe a little bit more medial on some of those cases so that the prosthetic or the platform ends up more centered and not so lateral.
Yeah, that tuberosity bone can really, and that's why, like, it goes back to what I said in the beginning. I like having the ability to really dictate that angle and be able to put pressure on it, because
100%.
I don't want, because it's so easy to hit that hard cortical bone and then just go off course.
Deflected.
Yeah, and in the tuberosity region, because sometimes
100%.
the bone back there is just like basically just fat. There's like nothing back there at all.
For sure. Totally.
I find too, like when I was first starting on pterygoid cases, I felt very dependent on there being a decent amount of subantral, like tuberosity back there to establish that glide path and can make, if I could just get the angle right the first time on the osteotomy and find the pterygoid, I was going to be okay because I had all this tuberosity to just keep me where I wanted to be. But then as I've gotten more comfortable, I've started dealing with less and less tuberosity. So something I'm curious about is, what are some of your kind of like limitations in terms of candidacy for someone to receive a pterygoid if they don't have a whole lot of tuberosity back there? If it's eggshell, I've done one where I took out an impacted third molar, huge void now, but I could still get the pterygoid. What are your thoughts around, do you need tuberosity back there? Is it doable without it? Is it okay to be intra or transsinus with your pterygoid?
Yeah, so I've done a number of transsinus pterygoids and they seem to be fine.
Yeah.
My thought process is, do I really need a pterygoid there for some sort of stabilization? And is it something that I'm adding it where it could potentially even be transitional, meaning that, let's say there's no subantral bone, I'm getting 30 newtons torque, there's only 3 millimeters of bone engagement at the apex, but it's good enough to load to help these other implants heal.
Yeah.
And the spread of the other implants, if this fails, is still okay.
Yeah.
So that's my thought process on it. I've grafted a couple times where I go back, I move the membrane out of the way, I prep, I'll graft almost like you're doing like a sinus, a lateral wall and placement at the same time. So you pack the more medial side, you place the implant and then pack, and I'll do that. I've done that a couple times. Seems to be fine. The biggest issue is typically access back there. But yeah. One of the things too is transsinus gets thrown around almost like it's a thing that you can do all of the time. Like it's a technique, and hey, you could just do it like a transsinus. Whether or not we're talking about an anterior traditional transsinus or let's say like with the pterygoid, Brandon Mark has a really nice way of, it's categorized by basically this anterior part of the sinus and how it relates to the nose and the relationship of those two things and how much the body of the implant, it's almost like a Zaga classification, but for the sinus. Yeah. So there's a different spectrum of, when someone says transsinus, they might say 95% of the implant is in bone, but the body of it and one small section is in the sinus. Then you have other parts of it where it's like, hey, depending on the crestal portion, if you have more than 4 millimeters or less than 4 to 5 millimeters, you need to graft the area or not graft the area. So let's say you make a hole, move the membrane out of the way, puncture through, place the implant, but you've got a good amount of bone on the subantral part, say 5 millimeters. Hey, you probably don't need to graft that mid body, but the idea is you've got 3 millimeters at the apex, let's say at least 3 millimeters of engagement at the crest. That seems to be, and I don't know if there's any studies on this, but I think the studies that are out there, 6 millimeters of osseointegrated implant seems to be about the minimum that people are okay with as far as loading. So whether it's transnasal or whether it's transsinus or whether it's transpterygoid or whatever it is, the suggestion is 3 millimeters of osseointegration at the apex and 3 millimeters, regardless of the length of the implant. And I'm not talking about zygomatics. I'm just talking about these other transsinus. You would have the 3 millimeters at the base and the 3 millimeters. That gives you your 6. Yeah. So same thing with your transnasals. You might have about 2 to 3 millimeters engagement in that conch area. And then you've got, or at the Z point, and then you've got, let's say 3 millimeters crest. So now you're at that 6 again. There's the difference being with, let's say, a transnasal, the bone quality underneath the piriform rim is significantly different than bone quality in a posterior transsinus. And that almost never gets talked about, where you could have 4 or 5 millimeters of bone back here. So technically it qualifies for not grafting your transsinus implant. The problem is that 4 to 5, if it's D4 versus D1 or D2, it would change how I would treat that patient, whether or not I'm going to graft or not graft, because I'm not counting on D3, D4, because the bone to implant contact at the platform area is going to be significantly different. Regardless of that height, it ticks the box. So same thing in the pterygoid area. If I threw my plasty or there's just no subancestral bone, there's just minimal there. Am I going to graft it? Am I not? It's much more difficult to graft back there than it is with the traditional sinus. But those are the things that I'm thinking about as I'm working through it and how that bone feels for those cases.
Yeah. Yeah. I can't even imagine grafting back there, to be honest. That doesn't seem fun.
Well, what's interesting is when you get into doing sinus lifts, when people start doing them, the place that they miss the most is this anterior part, because they're working back towards yourself and it's difficult to get to. So actually, when you go back there, depending on the cheek and just range of motion stuff, going back further, you're looking straight at it, and it's actually a little bit easier to get it out of the way. It's just whether or not you can pack stuff there and drill through it and have all that stuff. So
I can see that.
From an access standpoint, I actually think it might be a little bit easier than the anterior part.
Gotcha. That's definitely something to consider. I've got a few pterygoids out there that I feel like they kind of work similar to like a wheelie bar on a drag racing car, where I'm like, okay, like I got some stability here, but I don't know that much about how well this is really going to hold up long term because of what's going on near the crest. It's just, there's not a whole lot of bone there. Maybe it's really fatty. I placed this through this big space, and it's good to load, and it's going to help support those 4 front implants that are just going to act like the 4 tires of that drag racing car. Once they get traction, they're fine. But at the start, we need something to give that stability in the back. I think that's a decent analogy. I made it on the fly. But yeah, no, I'm curious about how those types of pterygoids will really hold up, how they stand the test of time. And mechanically, they're great for a loading situation. But what do I really need for that to actually hold up long term, to integrate and to be useful for throughout the life cycle of that patient? I don't know on someone.
Yeah. I don't think anybody does. So
yeah, we're seeing what happens. Yeah, no, I hear you on that. I hear you.
Chris, I think we're getting to the end here of we got enough content for 2 parts here, and we really appreciate you taking some time out of your Friday afternoon to be with us here on the podcast and discuss what you do day to day. And I know you just got off of a double today. I think you had a pretty long day yesterday too. So again, we really appreciate it. I think I'd love to, as a closing remark, just hear what maybe you're most excited for in our implant profession coming up. What's like the next big thing that you're excited about coming up here in implant dentistry? And then we can wrap it up and call it a night.
Things that I would be excited about in implant dentistry. I'm in the phase of my career where I've ticked a bunch of boxes that I thought were personal things that I wanted to achieve a little bit as far as some of the clinical stuff. So I think just some of the advancements in things like there's something called tetranite.
Yeah.
Really at it.
Yeah.
If someone comes up with just some glue or cement, you can just squish in there and put the implants in. And now all of a sudden we don't have to do any of this stuff. I think that's interesting.
Yeah.
I think some of the robotic stuff is interesting. I've been to 2 different Yomi lectures, and I know a guy here in town. I caught myself thinking some of the same stuff about, oh, I'll never do this remote anchorage stuff like a few years ago. And before it's gone, I'm doing a bunch of it. And it's, oh, I would never use it. Why do I need to spend $200,000 on a robot? And it's maybe in 2 years, I'll have a robot. I think it'll just be one of those things where I'm not sure exactly what's coming. I think some of it will be out of the orthopedic field, maybe some special surface coatings that can osseointegrate in a couple weeks. Just stuff like that. Just honestly, one of the reasons why I got into this is because general dentistry is fine. It's great. But to make an impact on someone's life, and my very first All-Next case was this young female, and it made such a huge difference in her life. And I didn't do the surgery, but I restored her. I was like, that kind of pushed me in this direction. And being able to treat more patients and get them to a really good outcome where it makes you feel like you're having like an impact through your profession. If we can get technologies or different things to allow us to treat more patients and do it easier, where we just make a bigger impact, I think that's something to look forward to.
I like that. That's great.
Yeah. I think that.
How about you? What do you guys, you're at a slightly different phase than I am. What are you guys excited about?
I think for me, I agree with all the things you said. I've thought a lot about most of that, especially the tetranite. I haven't heard anything about that in a little while. It was like a big deal and then it just faded. Maybe it's going through some FDA approval processes. I don't know. But for me, I think more, a little bit less on the surgical side of things, because I think in the far future, people are just growing teeth and it's just ortho's going to make a comeback and we're just going to be guiding these like new tooth buds, right? Like it's just going to be a totally different form of dentistry, like a regenerative. We're not even there yet. But I think more on the AI side of things with digital design, digital planning. I want to get to where I can just take a CT scan and the AI is just going to take it from there. I just tell them what we need to do and it's got a prefab hybrid design ready for me to go ahead and just do the case. And then I'm going to submit the stuff in there to some other splicer or whatever. And it's going to spit out a hybrid case design right away. I'm very curious with how smart AI gets in terms of diagnosis, treatment planning, case design, how much easier and faster that makes it for us. And it could get to a point where we conduct the surgery, we take a few scans. It's probably going to be one like integrated device. We're not going to have separate photogrammetry for too much longer, probably. And then you submit everything. And then before you know it, your printer's already going off or your mill's going off, whatever the case may be. How many more things can get automated once we really start thinking with that sort of Web 3.0 type of mind? And to see just how far it's come, even just since I became a dentist, which is practically yesterday compared to a lot of leaders in our field, I think it's going to be really interesting to see what full arch and beyond looks like in 10, 15, 20 years. I don't think we can even really wrap our heads around that yet.
Yeah, I would say for me, I'm excited about 3D printed prosthetics and the material stuff coming up. I'm guessing in the next pretty soon we're going to have the ability to do everything 3D printed. We won't need to mill anything. Patients can basically be in a final same day. And if you need to make a change, it'll be very quick and hopefully pretty reasonable for us to do. I would love that kind of capability. And I think that's probably going to be coming here relatively soon. That's next on my docket for big things.
I want to see 3D printed arches that like the material can be a different color depending on the wavelength that it's exposed at. So you can have a single resin that will print out red and like different characteristics at different slices. And then you can just make a fully characterized final when it prints. I think that'd be really cool too. We'll probably see it.
Yeah, that makes a lot of sense. Some sort of chameleon effect. Yeah.
Yeah.
I talked with some guys about some AI stuff when I can't remember if it was ADSO or Dicom or what, but talking with them about like the Pearl guys and some of the other AI guys. I think that'll be really interesting. What I would love to see that I would actually get really excited about is if you could input all the patient's health history, you take the scan, you have all the Hounsfield units, and then you have basically this AI program that can basically walk you through the different treatments that are available for this patient and would give you the prognosis before you even start.
Right.
So you'd say, hey, we're going to use these implants. It's already been based off of the 3D scan that's integrated. MegaGen actually has like this CT scan that's facial, I think a facial scanner. So you do the CBCT, you get the facial scan, you throw it into their design software, and here's the design all in one thing. You do that. Now you've got Hounsfield units and bone density. Now you might take a blood test and you get quality of bone metabolism and like some other factors. And then you put all this together and say, hey, Mrs. Jones, and this is all within a shorter period. Mrs. Jones, here's your prognosis. You've got a 75% chance that this will last you 20 years based off of these factors.
I love
or something
that.
like that.
Yeah,
I don't think that's actually too unreasonable.
No, it's not. And I love that because that's kind of what I was alluding to with like treatment planning from the CBCT. It can give you different matrices of here's the chances that you'll need a quad zygo for this case, or you could probably use this and that. And it'll tell you like all the different anchorage points that you could use.
Yeah.
And I think there's just so many things. I love that you mentioned blood tests too. So many things that happen in implant dentistry and so many failures and complications that happen. Like we ascribe it to this is just biology. Things happen by chance. We just hope that something works. And if it didn't work, then maybe we don't know why. So we're just going to try it again. And hopefully it works the second or third time. These things are causal. Like there are deterministic things around it. We used to think that bone loss was just something that happened, right? Like you had to place subcrustal because you were going to lose 1.5 millimeters to 2 millimeters of bone no matter what. And we don't totally understand why, but yeah, it happens. So we just compensate for it. There's so many other things that when we know more about it and as AI learns and gets all that together, we can make more predictable dentistry. We'll have a better idea of what will work and what won't. It won't be so much just anecdotal feel, right?
For sure. I think for whatever you think about DSOs and large groups and them getting into education and different things, I do think a potential positive is just large data sets. I mean, you look at Clear Choice or something, if you could run through all of those things and say, hey, you can categorize down to the health histories and basically all of the failures come in with these groups of people and we can like weed all that stuff out. I think that's powerful stuff.
Yeah, for sure.
Cool.
Hey, Chris.
All right.
Thanks so much for joining us today. I know that we really appreciate it. I'm sure all of the listeners really are going to take a lot of golden nuggets out of this podcast as well. Thanks so much for being here. And we will see everyone next time on the Fix Podcast.
Thanks, guys. It's been a pleasure.